Hi, Dr. Kohli. Welcome to Acupuncture Medicine Day interview. My name is Latasha Tiffrey, and I am in my final year at AOMA. I will be in July or sometime this summer. I will be completing a degree in acupuncture and Chinese herbs. So I'll be getting an acupuncture license. So we're going to go ahead and get started with your interview. And our first question for you is for you to introduce yourself and tell us a little bit about the mission of People's Community Clinic and how you came to the clinic, as well as your role at the clinic.
Yeah, thank you for having me. I really appreciate being here. My name is Kohli. I'm a family physician, and I work at People's Community Clinic, as you mentioned. I'm in the adult and adolescent departments there. And People's Community Clinic is a federally qualified health center. Our mission is to improve the health of medically underserved and uninsured Central Texans by providing high quality, affordable health care with dignity and respect. We started in 1970 as a free clinic, actually, near UT, basically with volunteer doctors and nurses providing, healthcare to students who didn't have access, and eventually expanded and became just a place for working Central Texas families to come and get healthcare. As we know, Texas has the highest rate of uninsured citizens, and so as a result, people don't have access to care, so they often turn to federally qualified health centers like our own. I joined People's in 2018. I have worked in federally qualified health centers my entire career. Mainly, I started in California. I worked in rural and urban health centers out there. I was the medical director of a large site where we actually incorporate a lot of integrative practices, including acupuncture, naturopathy, Ayurveda, some manual medicine. And I was one of the, I was involved in the early days of an organization called Integrative Medicine for the Underserved, which basically it works to provide culturally responsive, integrative care for all as a way of sort of advancing health equity. So I co-created the annual conference, which about 10 years ago there. So I moved to Texas in 2014, and I served as the Director of Clinical Affairs for the Texas Association of Community Health Centers, which was sort of a position that supported all the health centers throughout Texas. And after a few years, I sort of, being in an admin role, decided that I needed to come back to a role in a health center working with patients. And so I came back to People's Community Clinic, and I'm working in both the adult and adolescent departments, as I mentioned. And one of the things that I've been working on for the last couple of years has been an integrative pain management program. Just with my experience in the past through I Am For Us and through my old health center, it sort of was, and a lot of the resources that People's already had, it was just pretty natural to sort of create this program that aligns with best practices, and we'll probably talk quite a bit about today.
Very nice. Okay, so AOMA has had a long-standing relationship with People's Community Clinic. Can you provide some history on our relationship?
Yeah, I mean, a lot of it, I mean, obviously predates me being there. But from what I understand is that AOMA and People's have had a relationship since 2003. So about 17 years now. And a lot of it is just we're a clinical site for students to come and be able to get some hours with a patient population that really needs these services, doesn't have access to these services. So it's sort of a win-win in some ways. The students get hours, our patients get needed services. I think a lot of the work in the past has been sort of siloed, kind of in the corner, not necessarily tied into the direct care that we provided at People's. And when we came in and started this integrated pain management program, we kind of, we worked with Dr. Billy Zachary, who at the time he was in this doctorate program, and now he's gotten his doctorate. And so he's on faculty at AOMA. And he was bringing students in, and they were kind of in one corner, and we started talking to him, and we're just like, hey, like, why don't we integrate you in better to our services? And so we, got him on our EHR. We started a referral system that works just like if we were referring someone to our behavioral health or our nutrition. It's just integrated in. And so we've now been able to sort of tie it into where it's more of a seamless transition. There's communication that happens between the primary care providers and Billy and the acupuncture team. And we've been able to expand within the pain program to be able to offer more acupuncture services as well. And so I think it's been a great relationship. I think we've really enjoy having the students. The students come. We have case conferences, on a weekly basis. And the students were coming out pre-COVID, I guess we'll say. They were coming to the case conferences and presenting cases at times and just interacting with the rest of our team as well. So I think it's been a great relationship, and we look forward to getting students back into our clinic and really just kind of growing that relationship as we move forward too.
So since we will be discussing the integrative pain program at Peoples, it might be good to first share your definition of integrative care.
Right.
How would you define integrative care?
So, that's a really good question, because I think some people are like, oh, integrative care. Well, we have an acupuncturist, we're integrated, right? But I think it's a much deeper definition, right? So the way I look at integrative care is that, it's patient-centric. So it puts the patient at the center. And it looks at all the factors that impact their health. So that could be physical, mental, emotional, spiritual, environmental, social. I think along those lines, especially when you're working with underserved communities, you have to look at social determinants and unmet social needs. I think if we're talking about root causes aren't that someone isn't eating right or someone isn't exercising. Root causes are, there's a reason some people aren't eating right. They don't have access to food. Why don't they have access to food? There are policies that basically are in place that don't prevent supermarkets from being in their neighborhoods. So there's deeper underlying root causes that cause this, and we have to look at those. We have to get further upstream. And I think that's really essential when we're talking integrative care. And so there's this new term of integrative health equity that really kind of talks about this advancing equity through this sort of integrative care. So that's part of it. But then the other piece of integrative care is expanding that toolkit, looking at all the evidence-informed therapies and treatments and practitioners who are out there, and say, hey, all of these can work to help achieve optimal well-being for people. It's not just about disease management, which is part of it, but it's also, how do we create wellness? How do we prevent illness? How do we create a system where people are really thriving? And so to me, it's a lot of that. It's expanding that toolkit. It's looking at all these root causes, but it is really expanding it into this realm of social determinants, which requires policy change. And so thus means that people need to be more active on an advocacy level, whether it's individually or with organizations that can help with that.
And so the integrative pain management care model Peoples has been held out nationally as a best practice. Tell us about the model and the role acupuncture plays.
Yeah, so I think our program aligns with the best practices that have been laid out by the Health Department, U.S. Department of Health and Human Services, Pain Management Best Practices Interagency Task Force report that came out in May of 2019. And so this report was created. I mean, this is after years and years of looking at the evidence of different types of non-drug approaches to pain, looking at best practices for pain through the Institute of Medicine's. They had a national pain strategy that's from 2010, 11, something like that. And so these strategies, what they are promoting is basically a biopsychosocial model of care, which is essentially an integrated model of care. But it uses a multimodal, multidisciplinary approach to with an expanded toolbox. So essentially, they're talking about what I just defined in around integrative care. They look at 5 different buckets of potential interventions that you can do. So there's meds, there are restorative therapies, there's interventional procedures, behavioral health approaches, and what they call complementary and integrative health. So the idea is that a patient would work with their provider through shared decision making, to look at their preferences and say, hey, let's look at all the things that are causing you to have pain potentially. Now let's look at all the toolkit, the tools we have in this toolbox, and figure out what you want. So that may mean someone gets, gabapentin and acupuncture, or maybe that someone gets surgery and yoga therapy, or new behavioral health approaches, and whatever, chiropractic manipulation. So it just allows you to kind of have this more expansive role. So our program fits in line with that. I mean, we'd actually developed this program prior to that report coming out, but this report helps sort of validate everything that we're doing and kind of gives us a blueprint as we move forward. But the idea is that a patient will come into the program and will see their primary care provider. The primary care provider will talk to them about the pain management program. If they need to give medications, they can prescribe medications, or they could potentially do a joint injection, whatever it may be. But they'll refer them to our care coordinator. And this is a really key piece of it, because pain is so complex, you need to be coordinating this pain. So then the care coordinator will let them know about all the different services that we have, and then patients can choose what they want. So that could be behavioral health, and that's where we have so many of our patients have experienced significant trauma, and trauma leads to more mental health conditions, but also chronic pain, and whether that's physical or emotional pain that they're feeling. And so a lot of it is really getting people connected to behavioral health to be able to help with some of these things. And there's a lot of different techniques, whether that's cognitive behavioral therapy, acceptance commitment therapy, mindfulness-based stress reduction. They have a few, EMDR. There are a few different options that they use. But then we can also get them connected. Another really important piece is we have a medical legal partnership. So we have lawyers on staff that can help patients with their legal needs that may impact their pain. So if someone is being threatened to be evicted, a lawyer can help with that. I mean, if that's on their plate and their stresses are there, that's going to cause them to hurt more. So the medical legal program really helps with that. Or they can get people on disability, which is huge, because then when they get on disability, they can access Medicaid and Medicare and insurance, which allows them to get some specialists, which they may not otherwise have. We can refer them over to a substance use counselor if needed. We have that on site. We have a nutrition program, so talking about anti-inflammatory diet and looking at how pain can be impacted by nutrition. We have exercise programs. We used to have Zumba before COVID. And then we have, of course, acupuncture with not just the student clinic, but also, and they do a wellness hour with NADA, your acupuncture, obviously. But also Billy has expanded his hours, and he's now doing individual full body acupuncture. And then we have a yoga therapist as well, bilingual, bicultural yoga therapist, as most of our patients actually are Spanish speakers. And so, so we've sort of, and we actually had gotten a grant to bring in massage therapy, but with COVID, we weren't able to do that at this time. So we've kind of expanded these options for our patients. The other thing that we have are group medical visits, and that's a real, like the cornerstone of our pain program. Groups medical visits, for those who aren't aware, are place where it's sort of a value-based model where patients who may have similar diagnoses or just something in common come in and get their medical care in a group. So there's like a one-on-one component with the provider, which would be me. But then there's also a nutritionist and a social worker who are co-facilitating these groups. And it's a place where you have more time, so you can focus on self-management, on on things like nutrition or on movement. We do a lot of those components within it. But the biggest thing is that people connect with each other. They share with one another. There's peer-to-peer learning. They are teaching each other about the pain that they're experiencing in ways that they've been able to address this. And so, so it really breaks down a lot of the hierarchies that exist in healthcare, and allows our patients to really kind of feel connected and heal in community, which is great. And then the other piece about our program is case conferences. We do these weekly case conferences where everyone from all the different members, including our acupuncturists, and then we have, like as I mentioned, the students would come in. They would, be able to. We would all be discussing cases with one another, and complex cases. And since so many of our patients, had like these short-term life crises, our social workers and our lawyers were so important in that. But being able to get the perspective from like Billy and his team was just it's really great, because it's really refreshing, because it's different from what like we usually hear in our clinic. So, so essentially, this is the program. It's been adapted a little bit because of COVID. We've had to do some of the stuff virtually. Acupuncture had to stop for a while, but we're about to restart it using like new safety protocols that we've developed with AOMA. And our goal is really to improve quality of life. And that's what we're hoping with our patients.
Very nice. Okay, so one of the challenges in changing healthcare in this country is getting the Western medical community to consider the use of alternatives like acupuncture. In your opinion, how do we help overcome this barrier that is arguably keeping most in our community from a care model that has proven to provide better outcomes without medication and at a lower cost?
Yeah, it's a good question. I think for the longest time, I mean, the argument was that, well, there's just not the evidence to support that this works or that works, and that's not true anymore. We have a lot of evidence now, and so I think now the biggest factor is for payers to catch up with the data that's out there. I mean, I think we have, now we have not just the data like individually for acupuncture, but and for yoga therapy or for chiropractic or any of these other things, but we have this HHS document, which I referenced, which is essentially, 150 major medical organizations, including the American Medical Association, major pain organizations, American Psychological Organizations, support this document, which includes things like acupuncture, chiropractic, yoga therapy, et cetera, as potential treatment options. So I think there's going to be a movement towards it. I think pain is sort of the opening, right? Like this is where whether like the opioid epidemic is allowing us to really we don't have great options in our Western medical model for pain, right? We can give you pain pills or we can do procedures on you, and they can be effective, but they're not, we know that opioids, the problem that opioids have, and that they're not great long-term options for pain. So knowing that there are other tools out there like acupuncture or chiropractic or yoga, that allows us to really kind of expand, the offerings. So now I think it's a question of whether we can have the payers catch up and say, all right, like we're going to cover these things, because until that happens, people aren't going to say, oh yeah, let's bring in acupuncture. There's no way to reimburse it, but we'll just bring it in, right? So you have to have the insurance company saying, okay, well, we're going to cover this. I think the fact that Medicare now, starting in January, has started covering acupuncture for low back pain is a great start. I think it's really important. I mean, but there's still some limitations around it. It requires supervision. We don't know a lot about how much in an FQAC we're going to get paid for it if that happens. So there's still a lot of question marks around that. But I think there's going to have to be changes in the Social Security Act, which figures out who are billable providers in Medicare. I think that part of it is just we just have to keep educating folks and really go out there and just say, like, I just did a talk for the Texas Medical Association around non-drug approaches for pain and what are effective. And part of it is we have to be able to just say, hey, what we've been doing for so long hasn't worked. Giving opioids to people has led to this problem. And there are safer alternatives out there, and there are more cost-effective alternatives out there, and we need to start using these. And so I think part of it is moving in that direction. And I think, like I said, I think these HHS best practices are a great opportunity to kind of really talk about this. And I think other clinics, because as this goes in through HHS, that means it's going to HRSA and the Bureau of Primary Healthcare, who oversees the whole health center program. And there are 30 million people who go to health centers. Involves CMS, SAMHSA, CDC. All these are under HHS. So as this filters down, these are going to become the guidelines and the best practices, which means that these sort of therapies need to become the reality. So I do think that there's going to be an opportunity for that. The other thing I think is important to mention, and it's just, we have a lot of health inequities in our system. And I think, and part of that is also if you want to bring acupuncture to communities that are facing health inequities, you need to have a more diverse workforce as well. And so there has to be, addressing, and this is not just for acupuncture, this is like most of the integrative health field as a whole. How do you increase diversity and address the inequities in sort of the recruiting practices of schools to be able to, I mean, if you think about the history of acupuncture in the US, I mean, a lot of acupuncture has been done with marginalized communities. I mean, whether that was the Chinese immigrant population that was here, but then even in the 60s and 70s with the Black Panthers and the Barefoot Doctors, and then the Young Lords and Mutullah Shakur, creating the NADA protocol. I mean, this has been, because there's been a need, the people have been marginalized and not being able to access the main medical system, they've had to turn to other alternatives. And so these are things that we have to know this history. We have to know that this is important. Increase the number of practitioners who come from communities that are impacted by health disparities, and really just kind of be able to, as be able to get trust and work in those communities. I'm really encouraged. There's one of the former grads of AOMA, Rhonda Coleman, along with Tanisha Dandridge, who've been involved with an organization called, they just founded the Black Acupuncturist Association. And so it's really exciting to see like this sort of coming up, and that there's more movement in that direction to really just like kind of make this field more inclusive and actually, be able to impact communities in a positive way. So.
Very nice, very nice. So our last question for today is, what is your vision of other chronic conditions that could effectively be treated with an integrated approach that includes acupuncture?
Well, I think all chronic conditions can do that. I think the reality is like, what we're doing in our clinics, we've sort of built this pain program. And really, again, it isn't because pain is any more effective for this than doing this for diabetes or whatever else. It's that, I mean, there is an opportunity to do it because there's funding now around opioids, and there's a way of sort of preventing people from going on opioids by using these things. But our goal is to really expand this sort of integrative care, this program using not just acupuncture, but behavioral health, massage therapy, yoga therapy, et cetera, for all the care that we provide. And everyone has their own expertise, and we need to learn from each other to see what we're really good at treating. But I mean, I foresee us being able to provide this type of care and really changing, this from this disease care model to one that's focused on well-being and wellness. And I think things like Chinese medicine, acupuncture, and yoga, and naturopathy, all these other things have sort of this view of like, let's bring the body back to balance. Let's sort of be well. It's a different view of healthcare than one that we see in the Western medical model. And so, to me, you can have people's numbers. Like, let's say we have a diabetic and their A1C comes down, and it's like 6.8, let's say. Does that mean they're well? I don't know. Maybe, probably not, maybe not. But so how do we like measure well-being? Like we need to really take a different look at how we do this. I mean, we're actually just starting to pilot some measures called the Flourishing Measures, which look at like what patients value in life. So there are a lot of questions on there, more like, do you have like good relationships in your life? Like, how do you feel about your overall health? I mean, they're more broader questions about health as opposed to specific disease-focused questions, or like getting a number, like, what's your PHQ-9? Oh, it's a 15. Oh, well, that's not good. It's like patients don't care about that. Like, patients care about whether they're able to do the things that they love and that they were able to do in the past. So to me, I think like this, it's really, this type of care where we're coordinating care, we're working cooperatively, we're expanding our toolkit, we're learning from each other. I mean, this is just good medicine. This isn't really integrated care. This is just good health care. And this is what we should be doing. And I think we are moving in that direction. And I'm hoping that, pain is one opportunity to prove that it can be effective in something that's super complex and really difficult. And then once you do that, you can say, hey, this is great for diabetes. This is great for hypertension. This is great for depression. This is great for all these chronic conditions as well. So that's where I'm hoping we're headed. Very
nice. Yes, and I agree with you on that. Do you have anything that you would like to add to the discussion?
No, not particularly. I mean, I'm really happy to be here with you guys. I think this is great to celebrate acupuncture and Chinese medicine and AOMA as well. So appreciate you guys having me for this.
And we thank you once again for being willing to participate as well in our Acupuncture Medicine Day. And we hope to hear from you more in the future. So with that, I guess we'll go ahead and close our session. And once again, thank you for coming out, and thanks so much.